The pharmacy world, medical world is a lot based on HEDIS measure. For pharmacy, it's a lot about Medicare star rating, such that they set a number based on adherence, based on clinical education data, and the goal is to try to reach these results. But you know, our goal is really not to just reach those results, but really drive clinical outcome results. Not being 80% adherent to therapy, but being as close to 100% to therapy as possible. So this is just some slides on the patient care facility that we have at most of our Safeways. So I want to begin with a quote from former U.S. Surgeon General Sierra Coop: "Drugs don't work in patients who don't take them." This is a topic of discussion I hear in a lot of conferences, and even from some of the doctors that I talk to. And the thing is this, you know, despite the best efforts from doctors, nurses, pharmacists, the success of the treatment plan really depends on the adherence, the patient's adherence to the treatment plan. So, just to give you some numbers, medications actually, 20–30% of the prescriptions that doctors write don't even make it to the pharmacy. And of those who do, the adherence drops off after 6 months. And you can see from one of the reports that only 51% of hypertensive patients remain adamant or remain adherent to that long-term therapy. And for statins, only 25–50% are adherent to that therapy. And CVS Caremark did a report, I believe 2014. They estimate that the medication non-adherence issue costs us about $290 billion. And when you think about this as our population starts to age, by the year 2020, it's estimated that there's going to be over 150 million people with at least one chronic medical condition. So you can see that number in terms of the 290 billion is probably going to be even higher in the years to come.
So we're only going to have like 5 minutes.
All right, that's all I need.
I apologize.
Nope, that's all I need. Thank you. All right. So some other numbers in terms of the clinical burdens with non-adherence. 30–50% of treatment failures, that results in 125,000 deaths annually. For statin non-adherence, you can see that increased mortality rate up to about 25%. And for cardioprotective medications, the increased risk of cardiovascular hospitalization is going to be about 40%, and mortality about 80%. So you can see that with poor adherence, you're going to lead to increased hospital utilization, increased ER visits, and approach that $209 billion annually. So this is a report from the Congressional Budget Office in 2012, and they show that every % increase in prescription fills actually will equivocate to 1% decrease in medical service spending. And not only that, when you think about the increase in refills, you have to think about that increase in pharmacy visits. And what if, during those pharmacy visits, you can actually measure blood pressure, A1C or blood glucose, or statin, or cholesterol, and report that back to the physician. So that in between the physician visits, the doctor will have some numbers as to where the treatment goals are, or the patient's treatment is. All right? So the way we do this is, one is with the interprofessional team-based approach. And you know, we know that when we operate in teams, doctors, nurses, pharmacists, it's going to be much more successful than working in silos. Just to give an example, you know, doctor's office get faxes every day about prior authorizations, drug not covered. But how many doctors get a fax letting you know that your patient is potentially non-adherent to the therapy? How many doctors get a fax saying, you know what, Mrs. Jones, over these last 6 months, is potentially missing medications for about 50 days. I don't imagine a lot of you do. But imagine if you have that data, that's going to assist you with managing your patient and making therapeutic adjustment based on that non-adherence versus just based on the lab values, right? It also has to be patient-centered, where we take into account of behavior, health literacy, cultural costs, and so forth. I was seeing a diabetic patient last week, and got the first time he's diagnosed with diabetes. Got a script, metformin 500, one with each meal. That's all I got. So I talked to him, I said, well, do you know how to take this? It's number 90, so this is a 30-day supply. well, I just take one with each meal, and I go work out 4 o'clock in the morning, so I'm just going to take this twice a day. That's what he told me. And the thing is, we have to take into account, and I eventually told him you have to take this 3 times a day as instructed by your doctor, and the points of why you need to do that. But I think to keep this patient-centered and make sure that we address factors such as behavior, cultural, and health literacy is going to improve that clinical outcome. Effective exchange of health information, as I mentioned, is when everybody involved, all stakeholders, have knowledge of therapeutic changes or gaps in therapy, you're going to be much more prepared. The team is going to be much more prepared and more effective in helping manage that patient. And then lastly is medication therapy management, which a lot of us have heard about today. So quickly, I'm just going to go over the Safeway MTM care model. And I think Nancy alluded to the Outcomes platform already. Outcomes and Marixa, they're what's called an MTM vendor. All right. So what they do is they have contract with health plans, different health groups, and they would use the adjudication data, all right, to triage and identify those patients who are at risk for an adverse medication event. So there's 2 categories of service. There is a CMR, which is a medication or comprehensive medication review, and there is a targeted medication intervention. So based on the adjudication data, the Outcomes and Marixa platform can extrapolate that to identify patients with certain disease states and certain risks for medication adverse events. We take those opportunities. We have a person called a clinical lead pharmacist who is solely involved with MTM, and they would take that queue of patients and interventions and basically triage those to our clinical pharmacists who would actually go out to the pharmacies, in the areas that they cover to provide face-to-face medical or medication consultation. The other thing the pharmacists do, the clinical pharmacists do, is that they can do telephonic appointments. So for those plans that allow telephonic appointments, or for patients that have transportation issues, this service can be conducted by telephone, and we demonstrated last year that we were quite successful in doing that. From these services, we then identified medication adherence issues, medication discrepancies, drug-drug interactions, or high-risk medication for the elderly. And we communicate that back to the provider so that they can evaluate the information and then make the appropriate medication changes or therapeutic changes. So some of the possibilities that we can see in terms of helping improve the hypertension management for Sacramento County is, what if we have pharmacists, these clinical pharmacists that's embedded into certain areas, collaborate with community providers to offer and transmit blood pressure readings with each prescription refills. So with each refill, we measure their blood pressure and communicate that back to the doctor through Epic, the Healthcare Information Exchange, or through some other portal. That will allow for true collaboration among community providers and stakeholders, and offer a model where we really have a safety net and an interprofessional structure to really help manage patients, making sure the doctor, the nurses, the pharmacists are aware at all times with the clinical management as well as the medication management for the patient.
Just a few minutes, so do we have any questions?
I have a question following on both presentations from Safeway, very energetic, very good. To add to those, to the possibilities, as it actually is a Safeway consumer myself, one of the things that I was impressed with a couple of months ago was the screening process that Kaiser uses. So they are screening across all kinds of clinics and providers for hypertension. And Safeway, as well as others, have self blood pressure. They have cups for everybody to do that themselves. The thing that I've thought various times is, boy, if you have that and you found somebody who was to be newly diagnosed hypertensive, to figure out a way to rope them in so that little point of service blood pressure cuff says, this result is high, go see, and maybe it doesn't because when I check mine's okay, but otherwise go see the pharmacist before you get out of there so that somebody ropes those patients who may not have been screened yet effectively into the process, and at least a fighting chance of pointing them toward the doctor.
Right.
Any reactions to that?
Yeah, well, some of our pharmacies, and you probably see this at CVS or Walgreens as well. In Safeway, we have what's called a Solo Health machine. And basically, it's almost like virtual medicine or virtual telemedication, where you actually measure your blood pressure and certain other biometrics. And based on that blood pressure, it gives a signs of risk category. And tell you what your risks are. The other thing with the Solo Health machine, it actually allows you to input your PCP information so that the data can actually be sent to your PCP. So that's one way of triaging and directing the patient to seek medical attention.
Stan, that's the device used in your pharmacies that the pharmacist works with, correct? Or is that out?
That is outside. So the Solo Health machine is actually outside pharmacy, but inside the pharmacy itself, there's also what we call a wellness room that actually has a blood pressure cuff that the pharmacist can use with the patient and make the appropriate interventions.
Nice idea. One more question, Lisa.
I just wanted to say that, in most countries, pharmacists are revered even more than some doctors. And I just wanted to know if you have like a network, a relationship going with pharmacists in other countries that you can, dialogue and take tips from and that kind of thing. Because I've seen that the pharmacists that are in neighborhoods like barrios or ghettos are, almost like the gurus of that everybody goes to them, even after the patients get prescriptions from the doctors and they've been told what they are and everything. They won't take them unless they're okayed by the pharmacist and they're explained by the pharmacist. So I just wanted to know if there's anything going on like that, like, network, get the conferences going together, kind of thing.
Marilyn just got back from Germany. So maybe you could take
I
a
think
stab at
that the model of community pharmacists varies dramatically all over the world. But in Europe, the community pharmacists have other levels of drugs that they prescribe behind the counter. There's a varying level, and you're right, a lot of the care happens in the community pharmacy. But I will tell you, they're just as disconnected as we are when it comes to information exchange between a pharmacist and another healthcare provider. There's a fabulous initiative in France with the community pharmacists in France where they are connected completely electronically with the primary care providers throughout the country. That's the first sort of thing we've seen where there's actual true information sharing between the community pharmacists, more than just the drug record, but everything, and they have the portal to communicate back and forth to the provider, because in France, the pharmacist has an expanded scope of practice. They have these other levels that they can prescribe. So they're the first to actually get in there and do it, and to connect their health information system to community providers. So we'll see how that experiment works.
Great. Thank you, Stan. Thank you to our speakers today, and thank you for sticking around to the end. Don't forget, for those of you who would like CME, the CME packet and the evaluation in your packet, if you can provide that to us, and we'll see you next month. Thank you.